All right, so I think we'll begin. Welcome to today's webinar. The title of the program is What Changed and Why It Matters, Understanding the Childhood Immunization Updates in DMV, and there's the District, Maryland, and Virginia. My name is John Gräbenstein, and I'll be your moderator today. This webinar is hosted by the Expert Vaccine Analysis Team, EVAT, of which I am a member, as well as the Institute for Public Health Innovation, Immunize Virginia, and the DC Vaccine Alliance. A few housekeeping items as we get started. The webinar is being recorded. Participants are on mute. Please use the Q&A function, to submit questions to the presenters. We'll address the questions after they've all presented. And we'll send the webinar recording to everyone who registered shortly after the session concludes. We have a tremendous panel of expert speakers today to discuss the real-world regional implications of the January 5th, 2026 HHS changes to the childhood immunization schedule. Our guest speakers are going to address what changed, why it matters, and how the update will affect clinical practice, public health programs, school requirements, and vaccine confidence across the DMV region. After the presentations, we'll have about 15 minutes for participant questions. Please remember, it's the Q&A function that you'll want to use to submit your questions. They can come in at any time. That'll help us organize them and make for a coherent session. So let's go to the first speaker, and I'm pleased to introduce Paul Offit. Many of you know the name. I'm glad that for some of you, you'll be maybe the first time you get to spend some time with this accomplished physician. He's director of the Vaccine Education Center at Children's Hospital of Philadelphia, CHOP, and the Maurice Hilleman Professor of Vaccinology, as well as a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Paul has many years of experience on FDA's Vaccine and Related Biologic Products Advisory Committee and the CDC's Advisory Committee on Immunization Practices. He's a co-inventor of the rotavirus vaccine that's used in the United States and many other countries around the world. Paul, no further ado.
Thanks, John. So on January 5th this year, the Department of Health and Human Services changed the current childhood immunization schedule. They did it without working groups. They did it without any expert advice. There were no data presented to the Advisory Committee for Immunization Practices. It was just a unilateral decision made behind closed doors, pretty much at the whim of our Secretary of Health and Human Services. So I'm going to go through the way that they've made changes. Or if you count the meningococcal vaccines, ACWY and B as 2 vaccines, basically we're talking about 19 vaccines. So 11 vaccines continued to be recommended as before. And those were the DTaP vaccine, the pneumococcal vaccine, the Hib vaccine, the inactivated polio vaccine, the MMR vaccine, the varicella-zoster vaccine, and the HPV vaccine. There was no information given as to why these vaccines were considered to be more important than others, why they continued to be recommended clearly without any reservations. No idea. Now, 3 vaccines were removed from the recommended category to what is called shared clinical decision-making. Those 3 vaccines were the rotavirus vaccine, the influenza vaccine, and the SARS-CoV-2 or COVID-19 vaccine. Now, what shared clinical decision-making means is you're making a decision. And so you could reasonably make a decision not to give any of those vaccines. What's interesting is all 3 of those vaccines share one thing in common. They're all short incubation period mucosal infections. The goal of all 3 vaccines is to keep you out of the hospital, out of the intensive care unit, and out of the morgue. But the goal of that vaccine, none of those vaccines have the goal of eliminating the virus. I mean, those viruses will continue to cause mild or moderate disease. They will continue to circulate every year, even if the entire world were vaccinated every year. That's the story with short incubation period mucosal infections, which means that a choice not to get that vaccine is a very real choice to perhaps suffer those infections. Now, the rotavirus vaccine, when it was introduced, the first rotavirus vaccine in 2006, reduced the incidence of hospitalizations by about 80 to 90%. When there were 55,000 to 70,000 hospitalizations a year, My pediatric residency was dominated by children with severe dehydration, primarily between 6 and 24 months of age. I spent most of my time on the infant floors, putting in IVs. I can only imagine the people that constructed this new schedule spent no time on the infant floors during winter months before there was a rotavirus vaccine. Now, influenza also, this virus continues to circulate. Last year, 2025, there were 289 pediatric deaths from influenza. This year so far, there have been 44 reported, and my understanding is now there are more. Nonetheless, recently, just in the past week, Robert F. Kennedy Jr. on CBS News said that he thought children might be better off not getting a rotavirus vaccine, saying that the rotavirus vaccines don't prevent hospitalization, which is not true. The last three seasons, 2003-4, 2004-5, 2005-6, the rotavirus vaccine protects against hospitalizations, depending on which year you looked at, anywhere from 50% to 67%. And then regarding COVID, Fiona Havers presented to the CDC back when we still had a CDC in April of 2025, going through what was our experience with COVID among children in the past year. And she found that there were about 10,000 hospitalizations from COVID. 20% of those children who were hospitalized were admitted to the intensive care unit, and there were 152 deaths, which is why the American Academy of Pediatrics immediately stood up and said this is a vaccine that is recommended for young children because it can be severe. Now, 5 vaccines were reserved for what was called, quote, high-risk groups only. And those 5 vaccines were the respiratory syncytial virus vaccine, the hepatitis B vaccine, the hepatitis A vaccine, and then MEN ACWY and MEN B. Now it's odd that one would refer to those as high-risk groups. I mean, what's a high risk for RSV? Breathing next to somebody who has RSV. That puts you at risk for RSV. I mean, what's a high risk group for somebody getting hepatitis A? Eating at a restaurant, for example, would be a high risk group because if one of the food handlers has hepatitis A and doesn't adequately wash their hands, you could be exposed to hepatitis A, which happens all the time. There were several thousand cases of hepatitis A in the United States last year. There were about 80 deaths from hepatitis A. So this is a virus which is still around. For meningococcus, that would be sharing a beverage, being in a dorm room, for example. These are all risk factors for Men B. And again, breathing is a risk factor. And for hepatitis B, to make that shared clinical decision making is to ignore the fact that there are millions of people in the United States who have hepatitis B, chronic hepatitis B. Most of them don't know it. At least 50% of people with hepatitis B don't know that they're chronically infected. Because when you get hepatitis B as an adult, you may not have symptoms and then go on to be chronically infected. Now, this is not AIDS. If you live in the house of someone with HIV, you're not going to get it, assuming you don't have intimate contact with a person who has HIV, like sex or sharing needles. But this is not AIDS. I mean, hepatitis B, despite the fact that it's an envelope virus, can live on surfaces for up to a week, and there can be large numbers of virus particles in blood. So if you come in contact with someone who has chronic disease and share, for example, toothbrushes or washcloths or towels or nail clippers, you could be at risk for getting hepatitis B. And before there was a universal birth dose for hepatitis B in this country in 1991, there were about 16,000 children who had hepatitis B, children less than 10. They weren't getting it from being sex workers. They weren't getting it from using drugs. They were getting it from, half were getting it from their mother. The other half were getting it from relatively casual contact with someone who had chronic hepatitis B and didn't know it. Your nanny, the person in daycare, and that's why we had the universal birth dose for hepatitis B, and we pretty much virtually eliminated hepatitis B in children less than 10. They're trying to loosen that, they being the new Secretary of Health and Human Services. So the point being is that although they call it a high risk category, everyone's at some risk. There are no risk category. And then lastly, I just want to say that I think for the most part, my sense from talking to pediatricians is that most pediatrician practices are ignoring this recommendation. It's not an ACIP recommendation. It's something that came unilaterally from Health and Human Services. Although they're certainly getting more questions, our pediatricians, and you guys know this probably better than me. I am having a lot of pediatricians call me and tell me they are ignoring the ACIP because there is no ACIP anymore. They're ignoring the CDC because essentially there is no CDC anymore. So the good news is the American Academy of Pediatrics has stood up, puts out a recommended schedule that is science-based, unlike this current schedule that was put out by HHS. So I'm choosing to believe that we will continue to look to the AAP, or perhaps even state or coalition advisory groups to get the best scientific-based recommendations. Thank you.
Paul, your hallmark is clarity, and you've done it again. So thank you very much for that. Let's keep moving on so we can cover the waterfront in a lot of different ways, Maryland, Virginia, the district, and also get to your questions. So please next introduce Dr. Lucia Donatelli, who's chief of the Center for Immunization for the Maryland Department of Health. She's a fellow of the American Academy of Pediatrics. Before that, her current role, she was chief of Animal Services, Communicable Diseases, and Environmental Health for Baltimore County Department of Health. And Dr. Donatelli, please.
Okay.
She's going to share her slides, so I'll give you a little audio.
There we go. I think I got it.
Here we go.
Can you all hear me okay?
We see your Zoom screen.
Okay. Can you all hear me?
Yes.
Yes.
Okay, great. All right, thanks for having me. And I'm going to start by providing a timeline of events leading up to the
So we're seeing your Zoom screen. We're not seeing your slides.
Oops.
You may need to change which choice you make on share.
Uh-oh.
Go back to the share button.
Try it again.
Okay, try it again.
Sorry, I know we're on a timeline.
It's okay.
Got share.
Here we go. Start.
Okay, sorry about that.
Legislative actions.
Okay, so I will be talking about legislative actions to safeguard vaccine access in Maryland. In 2024 and early 2025, officials anticipated some disruptions to vaccine information and availability and took short-term steps to safeguard immunizations by passing legislation such as House Bill 76, which authorized pharmacists to order and administer flu and COVID vaccines to those 3 years and older without a prescription. It also had them administer other ACIP recommended and FDA authorized vaccines to individuals 7 years and older. There was House Bill 1315, which required Maryland health insurance carriers to cover vaccines as health insurance for vaccines as recommended by the ACIP as they stood on December 31st, 2024. And these legislative actions positioned Maryland to be one of the states with the broadest vaccine access in 2025 per an article by the Kaiser Family Foundation. In September of 2025, when the CDC shifted COVID-19 vaccine guidance for healthy adults and children to individual clinical decision-making, Maryland issued a statewide standing order as well as a clinician letter authorizing and recommending healthcare workers to continue vaccinating for COVID-19 based on medical organizations such as the AAP, AAFP, and ACOG. Maryland established a webpage to answer frequently asked questions, and state of Maryland, along with Baltimore City, joined the Northeast Public Health Collaborative. In November of 2025, when the CDC modified the language on its website regarding the link between vaccines and autism, stating that studies have not ruled out the possibility that infant vaccines cause autism, the Maryland Secretary of Health, Secretary Seshimani, immediately issued a statement refuting this claim and reiterated the state's commitment to protecting vaccine access. And a day later, the Maryland Vaccine Program, the MVP, was launched, which expanded immunization access for uninsured and underinsured adults. In December of 25, when the ACIP voted to remove the hepatitis B birth dose from the universal routine immunization schedule for infants, again, Secretary Seshimani issued a press statement emphasizing the importance of that birth dose for all infants. Maryland created a webpage again to answer more frequently asked questions and issued another statewide clinician letter and standing order for hepatitis B using AAP recommendations. Last month, when the CDC updated the child and adolescent immunization schedule, modeling it after Denmark, reducing the number of routinely targeted diseases from 17 to 11, Secretary Seshimani issued a statement reaffirming Maryland's recommendation to follow the AAP childhood immunization schedule. And a couple days later, Governor Moore introduced the VAX Act of 2026, which secures Maryland's vaccine access by ensuring state-level, science-based immunization recommendations. In a nutshell, it mandates insurance coverage for recommended vaccines, expands pharmacy access, and empowers the Maryland Secretary of Health to act independently of federal shifts. So the VAX Act of 2026 is considered under two identical cross-filed bills, Senate Bill 385 and House Bill 637. It establishes a new authority for the Secretary of Health to issue official recommendations for not only immunizations, but screenings and preventive services for the state based on science and clinical guidance. It decouples the state's vaccine authority from federal government recommendations. Instead, the Secretary will be bound to follow authoritative medical organizations that issue independent recommendations, such as the AAP, AAFP, and ACOG. However, the Secretary may still consider federal guidance through federal agencies and federal task forces. The VAX Act of 2026 also requires that Maryland health insurers provide coverage at zero cost share for immunization screenings and preventive services, as well as the immunizations as recommended by the Secretary of Health. And it updates the language about the ability of pharmacists to administer vaccines to include Secretary recommendations. I wanted to give you all a little bit more detail about our Maryland vaccine program, which is our new state-funded initiative that expands access to recommended vaccines for adults throughout Maryland. This program eliminates cost as a barrier to essential vaccination services to help ensure adults in Maryland have access to life-saving immunizations. Now, children can still continue to access routine immunizations through the Vaccine for Children's program. So basically, the MVP picks up where VFC cuts off by providing the vaccines free of charge to adults 19 years and older who are uninsured or underinsured. The MVP program provides any vaccine as recommended by the American Academy of Family Physicians. And right now, this program is available through our 24 local health departments across the state, but we do have the intention of expanding providers to include FQHCs in the near future. I also wanted to mention another resource that Maryland has created, the Combined Respiratory Illness Dashboard, which combines the metrics from COVID-19, flu, and RSV for public use. So this combined dashboard may be used by professionals in epidemiology and healthcare to view emerging trends and focus prevention and resources. This data transparency can also allow the public to make informed decisions when traveling or attending major events throughout the year. And the dashboards for each separate illness is available separately as well as together on the combined dashboard. And then I just wanted to end with a couple of resources, and I think I am on time.
Great. Thank you, Dr. Donatelli. Appreciate that. We're going to circulate those references in the packet that will go out to the registrants afterwards. Thanks for the great review of the situation in Maryland. Let's turn to the District of Columbia next. I'm pleased to introduce Dr. Jessica Lazaroff. She is a primary care pediatrician at Children's National Hospital at the Goldberg Center for Community and Pediatric Health in Anacostia. She's assistant professor of pediatrics at George Washington University and affiliate faculty member with the Child Health Advocacy Institute. She previously served as medical lead for Children's National RSV Prophylaxis Program through 2024. Dr. Lazaroff.
Thank you so much. I do want to thank the DC Vaccine Alliance and our partners who are bringing this conversation together today. Like you said, I'm a general pediatrician. I've practiced in DC for over 20 years. And today I want to talk a little bit about what I'm seeing in DC and how we can help frame the conversation. So a little bit of a different direction. So what I'm seeing most clearly on the ground in DC right now is confusion. I should mention that the vast majority of families are still comfortable with vaccines. I want to make that clear. But I do see growing hesitancy, which isn't surprising. In just the past month, I've had parents who were previously very comfortable with routine vaccines pause, not because they suddenly don't trust science, but because they don't know who or what to trust anymore. I'm definitely seeing more vaccine refusals, more than I've seen in my career. And it's concerning that this is happening at this exact moment in time. Now, we do know that families rely on consistency when it comes to information, especially around childhood immunizations. So when the federal guidance changes suddenly and without any supporting evidence, it really does raise understandable questions for parents. And they're wondering things like, why did this change? Is something not safe? Who should I trust? And even if they haven't heard any specifics, they know that people are talking about vaccines more and they're questioning them. And we know that confusion is one of the strongest drivers of vaccine hesitancy. So there's been incredible work in DC to rebuild and maintain vaccine rates over the years. And though we do still see disparities across neighborhoods, even these small disruptions in messaging can really affect communities that already face barriers. And so the key message here is that trust is really hard to build and unfortunately very easy to lose. So at the same time, providers are navigating how these federal changes intersect with local public health guidance, school requirements, and all of the impacts to their workflows as they care for patients every day. But all of this takes time and resources, and we don't have a lot of that to spare. So what I'm saying is that the national changes don't happen in a vacuum. They show up in our exam rooms, in our schools, community clinics, and they take real time and energy to work through. So the good news is that DC's response has been swift and has really helped to cut some of the confusion. The DC Department of Health has been very clear in its commitment to protecting kids and maintaining vaccine confidence. So the key point for providers and families to hear is that DC will continue to align its childhood immunization approach with evidence-based guidance from the American Academy of Pediatrics, along with other major medical associations. That consistency matters. It gives providers clarity, and it really reassures the families. That overarching goal of having stability is, really minimizing disruption, protecting trust, and making sure kids don't fall behind at the end of the day. So that's why aligning messaging across clinics, pharmacies, urgent cares, and public health sites is so important, because when families hear that same message and the same reassurance everywhere, that confidence will hold. So this is where clinicians and immunizers have tremendous influence. And even though I know these conversations can be time consuming, and we know a lot of these things already, I'll just share some of the best practices that I strive for, especially now. So first, in this moment, we need to lead with calm confidence. Families take their cues from us. We need to clearly state what we know, what we continue to recommend based on that strong evidence, and the strong recommendation from a trusted clinician is key. Repeat that often. Also, a unified message within your office and organization is also important. So the second thing I really try to do is normalize the questions and truly be open to them. Saying something like, it totally makes sense that this feels confusing. That keeps the conversation open. And I also lean into curiosity. Vaccine hesitancy is not a monolith, and it may be driven by a family's lived experience and have very little to do with the changes in the federal recommendations. That's to say, I try not to make assumptions about what families are worried about. I ask and I really try to listen. And that's particularly important where I work east of the river and, where there's a lot of disparities. So I refocus the conversation on the protection. I bring it back to why the childhood vaccines matter and what they help to prevent. I use a variety of analogies to help explain immunology and vaccine science, just to make it more accessible. I think we underestimate the complexity of it to the average American. And I also try and keep the message simple and consistent. Short, clear explanations often work far better than longer ones. And that tried and true message that vaccines are safe and effective is still very powerful. And I'm also a really big fan of self disclosure. I do share that myself, my husband, who's also a physician, and my children they've all gotten all of the recommended vaccines on time because we trust them. And lastly, I think it's really important to keep equity front and center. The periods of uncertainty are when disparities really thrive. I think it's so important to partner with as many immunization coalitions and other community organizations as we can, so we can reach as many people as possible. And engaging those trusted messengers can be key because a variety of voices and lived experiences really should help shape our response. And this is really the time to unite our efforts for this impact. So I'll just close with this. The federal guidance may change, and it may change even more, but the science hasn't. At the end of the day, we know that clear communication builds trust, and trust protects kids, especially those already facing barriers. And how we show up in these conversations really matters. And recognizing the historical and current inequities in healthcare should really be part of that dialogue. So here in DC, just like in Maryland and in Virginia, providers and public health leaders and vaccine coalitions and all of our partners need to be united around this one goal, which is keeping kids safe and healthy with the vaccines that we trust. So with that, I'll hand it back to you. Thank you guys so much for having me.
Thanks, Dr. Lesrup. That was the voice of real world clinic time speaking right there. So that's great. I'm going to come back to you and ask you for how do you handle this kind of question stuff? But there's another speaker. So let's get to that one, or that him. The last of the four presenters is Dr. Michael Martin, who founded Einstein Pediatrics in 2016. Before starting his own practice, he had spent 10 years as managing partner and a clinical researcher at Advanced Pediatrics. He was president of the Virginia chapter of AAP during the COVID pandemic. So you got some media experience from that, I have a hunch. And in that role, he worked closely with the governor's office and the Virginia Department of Health, advocating for children and for pediatricians. So, Dr. Martin, we're glad you're here. And what do you have to tell us?
Thank you. Thank you so much for inviting me to this. This is awesome that you put this together. It's an pertinent topic. And I want to thank the Immunization Coalition for inviting me to speak on their behalf as well. So Virginia, it's definitely a different state. We have our own flavor. Northern Virginia has definitely remained with high vaccine rates. I think that's been evidenced by the recent measles cases that fortunately I think there's been 5 cases in the year. They've stayed isolated despite these folks traveling in multiple places through our state. So I think in Northern Virginia, that plays to the fact that we do have high vaccine rates, typically above 95% in school-age kids. Other parts of the state, Southwest Virginia, we definitely are experiencing more concerns and gaps in vaccination. And so we do have work in other parts of the state to do that. But I do think at the state level, the legislature has been very supportive. There's currently only one bill that I would label as anti-vax that's being heard either today or was late yesterday, which was a bill to remove hepatitis B from the school mandate. We're fortunate also, and I believe it was 2023, we had a bill pass that sort of froze school mandate required vaccines to what the CDC was doing at that time. Ironically, it wasn't necessarily how we wanted that bill to go, but sometimes when you're advocating for a bill and it's working its way through, you have multiple people putting verbiage and language in there. And so some of that got changed, but it actually works to our advantage. It doesn't make reference specifically to following the changes in CDC, but it locked in at 2023. So school mandates will remain in place as they are, regardless of what's happened at the federal level. And I see the landscape doesn't seem to be changing. The governor, as well as the legislature, seems to be very supportive of the existing school mandates. And so hopefully that remains as well. So I would start by saying, most families continue to want to vaccinate in Virginia, and particularly in Northern Virginia. We've seen a large number of families even requesting vaccines early as they perceive increased risk as these new guidance has come out of the federal government. What is changing is behavior of families. Especially in Northern Virginia, we serve a really highly educated population. They're asking more questions than they used to. We're seeing more requests, not just for early protection, but delays, looking at alternative vaccine schedules. And I would stress that it doesn't reflect widespread rejection of vaccines. I think it reflects more the uncertainty and people not knowing what to do and not what to believe. And in response, what I can probably say is uniformly across the board, practices are really leaning into this early, addressing concerns sooner, engaging families who are delaying vaccines, looking through the records to find who those folks are and actually actively engaging them, and reinforcing timely protection. So I would say, in our region, particularly in Northern Virginia, hesitancy really looks more like delay than outright rejection. There's certainly more people rejecting, but that's actually a smaller number. And it's an area where we can engage. Some people come in very fixed at what they're going to do, but there's a lot of people in that middle ground that just don't know who to listen to and are looking to pediatricians to help guide them in that. Um, in our state, most practices continue to follow the American Academy of Pediatrics. There has been a divergence. Even the hospital systems, Inova, I'm very proud to say, has also publicly stated that they're adhering to the AAP guidance. And so we're seeing that across from public health to practices to clinics are really following and lining up behind the AAP schedule that's been put out. It does affect how we deliver care, and I think others have hit on that. When we get into the offices, there's more conversation around vaccines than used to be in the past. Many families would take our advice, and certainly we would engage them on it, but there wasn't as long of questions and concerns that they have now. And so we've had to carve space for that. And so many practices are either carving it into the visit. Many, like myself, will actually have separate visits for those who are looking to delay or do an alternative schedule with their child. And so we're carving that space to be able to have the time to really address their concerns and questions on that topic. I will say what's really, really encouraging and actually surprised me. I will tell you, 10 years ago, folks did not want to engage in terms of pediatricians in practice, did not want to engage on social media as much and actually had a fear of it. They faced negative comments, negative reviews. It was ugly. And so many shied away from doing that. What's been really exciting is to see if we put a pro-vaccine message out there and someone does, put a negative comment, the community, our families are actually getting to it before we even have time to reply. And that's really bolstered our efforts and ability to be out there. And so I've seen a lot more practices, a lot more pediatricians engaging on that front with encouragement both from national AAP, but also I think at the ground organic level, they're getting some protected space from the people that they serve, which I think has been really exciting. I think one of the critical goals of messaging is normalizing vaccines. And I think it's become not in some communications outside of pediatrics, it's become unnormalized. But for us, it's really important to continue. This is just normal routine care that has protected kids for decades. And so that messaging, and I'm seeing very effectively done through practices, that's just part of the normal cadence and rhythm of things that we do and keeping it there. Another major strength I would say in Virginia is alignment. Before COVID, the lines of communication and collaboration among all the different agencies, public health, schools, practices, hospitals, it wasn't fluid. And so when COVID began, a lot of us struggled to find ways to collaborate. So thankfully, the good thing that came out of COVID is those relationships, those lines of communication are there. And so there's a more concerted, consistent message that we're all working together to put out to the public in one face. And that's made a huge difference, I think, because as families are getting different messaging, they're seeing the health community, the people that take care of their kids, that take care of their community's health. We're all saying the same thing, and we need to all continue to do that, and that needs to be everyone. So I would kind of summarize, to close, there's really three priorities here. One is alignment of the health community, which I think we're doing, but we need to continue to do and speak in one voice and really, really emphasize the importance and the science behind the AAP schedule. Two, and I'm super proud of independent practices. I think they're ahead of doing this, is really early engagement and communicating with families effectively. So I always, I'm an independent practice person, so I'm biased, but we're entrepreneurs. And so we're the people that can pivot. And there's some really, really good incubators of ideas that have happened in those practices and getting out the message effectively. And the third is, again, normalization. This vaccines are part of the normal things that kids go through to protect their health early on. It's part of the things that we do. It's not, and it's something that we want to engage and we want to talk about that are super important. But it is the normal flow of things, and it should be in most cases what kids receive. I think, in Northern Virginia, with our vaccine rates, schools above 95%, we're in a good position, but we have to be careful. Gaps can be created in small communities, and that's all it takes for an outbreak to happen. So why I talk about 5 cases of measles in our area and we're doing okay, we need to stay alert. We need to keep moving forward. And every practice, every pediatrician has a part to play in this fight.
Great, thank you. Each of you, that was crisp, a lot of great observations and counsel for practices and providers. So thank you for that. Thanks to each of you. And thank you for the crispness of your presentations. We got good content and efficiently in time. So thank you for that. Let's start handling some of the questions and answers. Paul, there's 2 elements to this first question, and one is, do we, so AAP is doing great work for kids and adolescents. That doesn't address what working adults should get and seniors and immunocompromised, well, by age, but you know what I mean. Do we try to get an alternative to the ACIP, a substitution, a replacement, a coalition of practice groups? So that's the first part of the question. And we're fine, and we heard this in some of the earlier comments. We're going to continue doing what we were doing in the 2025 schedule. Well, what if new vaccines come out? How do we who's in charge? Where's our consensus for what to do with new stuff?
Okay, so what we had before Robert F. Kennedy Jr. became Secretary of Health and Human Services is we had one place to look if we were trying to figure out where to get the best information about vaccines and recommendations, science-based information. And, I was on the ACIP, 25 years ago, but, you form working groups. Those working groups go through all the data. They then present those data to the ACIP, which votes on it. The process works. We don't have that process anymore. We have people making unilateral decisions behind closed doors that are based on their anti-vaccine, anti-science points of view. So we've lost this one central place to look. Now, the good news is people are responding. I do think the American Academy of Pediatrics, which has its so-called Red Book Committee, Committee of Infectious Diseases, which is also a group of, in this case, real experts who can give us science-based information and give us a schedule that makes sense. So the AAP has a childhood immunization schedule you can easily access online. That's the schedule. Now, what about if you have and similarly, there are states that have formed expert advisory groups. There are state coalitions that have formed expert advisory groups. So the good news is those expert advisory groups are experts. The bad news is it's fragmented. I mean, you have a lot now. You don't just have one place to look. You have a number of places to look. What happens if a new vaccine comes out? Again, I think that those expert committees will come up with, I think, the best information, and we will look to them. There is a lawsuit that's pending, by the way, and it started, lawyers are based in Chicago, but the venue of this lawsuit is in Massachusetts. You probably know about it. But the goal of that lawsuit, by the way, is to basically eliminate the current ACIP and to replace it with people who have an expertise in the subject, as compared to people who appear to be like advisors to Children's Health Defense. Meaning RFK Jr.'s anti-vaccine group. And they're optimistic, these lawyers, that they actually can do it. In any case, by Friday, I think you may know some information about that. This can't last. It can't. I understand that we have an administration that's not about to fire RFK Jr., but there's a lot of growing antagonism about this anti-vaccine stuff. And if you don't believe that, look at on CNN the other day, Med Oz was there talking about the importance of getting a measles vaccine. Now, that's something RFK Jr. hasn't been saying. So I do think that this is not a good look for the current administration. I don't think President Trump likes being the president of measles land. And you look at South Carolina, you're roughly 800 cases in South Carolina. You're getting to deaths now. Get to 1,000 cases, and you're starting to think about deaths from measles. So I do think people have responded the right way. I think sadly right now it's fragmented, but there will always be a place to go to get good information about immunocompromised children or new vaccines or existing vaccines. There always will be that place, but it may be more than one place.
Thank you. Let's go to practice-oriented questions. The patient comes in and says, I want to do my own research. How do you respond? Where do you point them? What do you do? Jessica, Mike?
Yeah,
Lucia?
I think, I think it's one good thing about all of this is that families are more interested in hearing about what these vaccines are. It used to be give them their shots. They don't want to hear about it, right? And so now they want to know what it is, what it protects against. And I think that that's good dialogue. I think that that builds trust and it helps engage and it helps, bring some agency to people caring for their kids. Now, so with that said, I do think that, when someone says they want to do their own research, you want to explain and sort of have the conversation of, well, here's where I would recommend to go. AAP. I used to say you can go to the AAP or CDC. And sometimes I say for the families that I see, I used to say that. And now I'm saying go to the AAP. And I explain what the AAP is, how long it's been around, and what their goals have been since they started. And then I also talk about there's a lot of stuff on the internet. Anybody can put anything out there. And we have to be really intentional about thinking about where the information came from, who put it there, and why. What's their motivation? What do they say their motivation is? And what is their true motivation? And a lot of my families are very adept at sort of getting to the bottom of people's motivations. And so I think it's super important to talk about there's misinformation and there's disinformation. There's information that is people think they're doing the right thing. And then there's some people out there that really have malintent. And so differentiating that and also saying, you know what, if you find something sounds concerning, print it out, bring it in, pull it up, whatever, and let's talk about it. And we can go through it. Again, it takes time, but people that want to do their own research, I think that some of that is great. The problem is that many of us were trained for many years to sort of interpret that research, and one snippet in a news article or on a website with sort of questionable origins can be tricky for families. And, that background trust is what really makes a difference in having these conversations about the complex, topics. So
Thank you for that. Mike or Lucia?
Yeah, I was just saying, I love these conversations, actually. I find them, I've done them forever. And I like when I get that word research, I'm like, the first time I asked, I remember there was a book from an alternative schedule, a doc who put out alternative schedule. It used to be common. Now I don't hear it as much, but that was their research. It was, they read one book. So that can mean so many things, just that alone in talking. I love to direct them towards certainly AAP resources and things, but sometimes it's getting at where is it coming from, and understanding the motivation of what they're really looking for, what their experience has been. And I think that's an easy conversation. They didn't decline a vaccine. It's like, hey, what led you to that decision? Where, most people are getting it, but I'm curious, can you tell me more about that? Just an open-ended question. And you're right, you have to have space. That's where I do my advice for practices when you do start to run into this is to create a space for it. You're going to have to be thoughtful in how you approach it because it's going to take you more time, but it is 100% worth it. And when you see the relationship on the other end of this, you've got a much stronger relationship. And that's what PEDS is about. That's why I went into it. That's why most of us have gone into it. We're building these relationships, and relationships happen with conversations. They don't happen with a stethoscope. It's the conversation that builds it.
Lucy, anything to
add? My interaction, I don't have direct interaction anymore. I'm not out in the field practicing anymore, but I do have interaction with providers that will call the state health department to discuss what is going on, particularly the local health departments. And one thing that we talk about a lot is meeting people where they are. So, it may be at the end of the session that you're not going to convince them to take the vaccine or the 5 vaccines that are scheduled for their infant. But maybe it's just one vaccine, or maybe you've gotten them to agree to look at the AAP website. And that's a win. So sort of, what I talk a lot about is sort of reframing what the expectation is, from the provider. And again, meeting wherever, meeting the patient, the family, where they are, and going from there.
Thank you. There's a question about VFC, Vaccines for Children, which is an insurance program, an entitlement program that the ACIP by U.S. law has a specific role in and enables, but if they vote certain ways, could remove. We hope not. What happens if ACIP starts changing VFC in a way that makes vaccines less accessible? Do the states have plans? Paul, are you any thoughts along those lines?
I think Lucia probably is the best person to answer that question.
Yeah, so this is something that we at Maryland have discussed ad nauseum. We are not there yet. The changes in the CDC schedule have, for the most part, been shared clinical decision-making changes, but there is no guarantee that that is, going to continue to happen. One thing that's important to note is with the HHS overhaul that happened recently of the child and adolescent immunization schedule, that was done by HHS, and VFC is tied to ACIP recommendations, not HHS. So there has to be a vote by ACIP, there has to be a VFC resolution, which is signed off by the CDC director, and we need to get guidance from the VFC program in order for us to make any changes in the VFC program. So, there is an ACIP meeting scheduled for the end of February. We are assuming that, the HHS recommendations are going to be voted upon. There is no agenda as far as I know yet, so we will see about that. But yes, we are discussing this and making plans for the future about, if that does happen, what are we going to do?
Is anybody billing for visits to discuss, or practice time, to discuss vaccines? There are some codes, I think there's some CPT codes or whatever the right word is for the codes. But I don't know that they've been well compensated or enabled or turned on. Am I doing that?
We've had success. Don't ask me to say what those codes are off the top of my head, but
the coding person.
There are, and I'm happy to get that information.
We want your coding person to talk to their coding person.
Yeah, exactly. I like the patient stuff, not the billing stuff. But no, we have had success. There are ways to do this. And it just sometimes takes a little creativity with scheduling but there are those of us who are doing it and are happy to give input on how to do it. I think every practice runs differently. So I do think each by practice, they have to find their path that works for them and their patients that they're serving. But there is a way to do this and get paid.
Measles, unfortunately, is in the press a lot, and my daughter and her husband live in upstate South Carolina, so they're watching it a county away. The outbreak around Spartanburg growing, and measles outbreaks like the tinder dry wood receiving a spark can, if there's enough susceptibles in an area, then you can suddenly have a lot of cases, and maybe those are clustered in a house of worship, or clustered in a cultural community, or clustered in an ethnic community of one sort or another. Are any of you doing outreach to such community leaders, as opposed to parents of individual patients, that to try to get ahead of this, I think there were some perhaps some infectious measles cases that moved through the district or the DC area a week or two ago. I think I saw a Washington Post headline.
So I can start with that. We have met with local health departments that we know have certain populations of focus in their jurisdictions to talk about what kind of outreach has been done in those particular communities. We have one jurisdiction that actually has on their local health department staff a member of a population of focus. So that is very, very helpful. But yes, we have done outreach, targeted outreach with local health departments.
Thank you for that. I'm not sure if you all can see the question and answer boxes or if only I can see them, but somebody commented the CPT codes are 90482 through 90848. So that's the place to go look it up in the coding book. Let's see, which ones are these are the most general use? So, Mike, you said you do clinical research. Do you see hesitancy spilling over to willingness to participate in trials and that sort of thing?
So I'm out of the business of research, so I can't speak to that. Maybe Dr. Offit, you might. I don't know. Yeah, so I can't speak. I would imagine there would be, but I don't. I can't speak to it.
It's probably situational and it bears on open mind and that sort of thing. The other thing CDC controls are the VISs, the vaccine information sheets, and there hasn't been any substantive change on those, although we see newspaper articles about FDA and black boxes on vaccines and that sort of thing. Anybody planning for if we suddenly have to find other sources for patient handouts?
Well, I definitely already. I mean, we used to use. I mean, for general handouts, we were using CDC for a lot, but in terms of putting forward the AAP messaging, like we're moving even the things that we may still agree with the CDC, we've moved away from providing CDC handouts. So we've really leaned into AAP to promote and legitimize what their recommendations and make sure people are, because I will say before all of this, I talked about the American Academy of Pediatrics all the time during COVID. I would, as a chapter president, I would talk. No one ever got the name right. People just weren't as familiar with the organization. That's changed. I definitely am seeing more people talk about it, but I do think it's important. All of us, as we're promoting that schedule, like we have to establish it as a legitimate organization that parents should be looking to for evidence-based, good, sound advice.
So back along the lines of I want to do my own research. So I'm the managing editor for the newsletter from immunize.org. Immunize.org has a treasure trove of resources for clinic staff and for providers. It also has two public-facing websites, vaccineinformation.org and letsgetrealaboutvaccines.org or letsgetreal.org. That also have a lot of patient-oriented, public-oriented, parent-oriented materials and vaccine information or vaccine education center, at CHOP that Paul's affiliated with does as well, and perhaps others that you want to give a shout out to that I might be overlooking.
But I just say one thing about the word research. So when people say, I want to do my own research. So for example, when the chickenpox vaccine first came out in 1995, I would hear that a lot. I want to do my own research, which generally meant, looking at other people's opinions online about, the vaccine. I mean, if you really want to do your own research at that time, you should have read the roughly 300 articles that were out there on the varicella vaccine, which would have meant some expertise in virology, immunology, statistics, epidemiology, et cetera. Most people don't have that expertise. Most doctors don't have that expertise. So what did they do back in the days before we lost our minds? What they did was they looked to groups like the FDA or the CDC who had advisory committees that collectively had that expertise, collectively had that research, had done that research and looked at those papers and came up with what they thought was the best advice. That's what used to happen. Now people believe they can just go online and know as much as any doctor who's giving them advice. I mean, especially in this realm. vaccines. I mean, I don't think people are going online then before they have a gallbladder operation and telling their surgeon how they want the operation done. But I think with regard to vaccines, people do think they can gather whatever think they need to know online. So that's what you're up against. That's what they mean by research. And so I think our challenge, and the people in this call have made that very clear, is to try and take that research, which at least many of us know, and try and convert it to a language people can understand, that and we present it in a compelling and passionate and compassionate way so that people can understand what the facts are, because it's amazing how much bad information there is out there, more than ever before. And it's the misinformation business is a good business. I mean, if you look at publications like the Center for Countering Digital Hate, the disinformation does, and look who funds them. They have tens of millions of dollars of funding from basically the wellness community and alternative medicine community, which has moved now kind of to the center of public health. That's the current grift. I mean, you'll never hear RFK Jr. He rails constantly against big pharma and big food, and for some reasons, not for bad reasons, but you'll never hear him go up against the wellness community, because that's who funds him and his allies. I mean, when he just recently said that he wants the FDA to back away from alternative medicine. That's what he's talking about. Let's get, Lupron back out there for autism, or hyperbaric oxygen therapy, or stem cells, or chelation. I mean, that's what's about to happen as that moves to the center of public health. And you'll never hear him rail against that. It's who funds him. It's a grift.
Thank you. For the last few minutes, let's come back to standard practices, because I think that's probably where most of our audience is coming from. And you've got a 2-month-old baby, and the parents have just figured out how to do the diaper thing. And you've got a 9, 10, 11, 12-year-old who's, HPV vaccine is in the picture, and they're approaching the adolescent vaccine window, and very different needs on those two sets of parents. What do you say to them? How do you start a conversation? How do you deal with some of the rocky comments that they might throw back at you?
Yeah, I mean, it's very different, right? So the 11 and 12-year-old, I've known them for probably 10 plus years. So it's a continuation of a conversation. There's challenges with it. But to me, that's a little bit easier because I know what I'm walking in, and my approach is going to vary depending on that family that I've known for a long time. I think the concerns of illness may be less than that population. And so exploring what those illnesses look like is often a conversation I have, and why it's pertinent to them. I think that's more the issue than concern of risk at that stage. The infant, you've been there 2 months with them through some tough times, so you've got some relationship. But it is different, and there's concern of this developing baby who can't talk yet, of what injecting a biological substance into their infant means for them. And so many of us will even start that conversation before that visit to prep them. I don't want to surprise them. I don't walk in the room. It's like, all right, you're getting today's three shots, and it's prepping them to let them know as a practice. There's constant points where we have that opportunity to sort of discuss, even when they enter our practices. And I encourage folks to do this, to engage them on where your practice stands on these things, educating them and engaging them on it before it happens. But yeah, I mean, it's case by case. And I think, again, I get back to, even with that research question, that's coming from somewhere. Like, what led you to want to research it? What concerns do you have? What have you read? What have you seen? And it is different with each family, and you have to be careful. I think sometimes we're in the rush of the day. We assume the common ones, but you're often wrong, and if you don't ask the question. And so that's how I encourage folks to get into that. And again, it takes time, and prepping the ground is helpful.
Sage advice. Jessica?
I would also add that that's amazing, and I agree with everything that you just said. The biggest thing is, in this day and age, and with all this perceived uncertainty, I lead with the presumption that this is what we're going to do, right? So if somebody comes in with a broken arm, it's presumed that we are going to have somebody fix it or send them to orthopedics. And I use that same presumption with vaccines. Now, it feels difficult because you're kind of bracing for maybe some pushback, but that's the skill that I really had to cultivate, is that presumption, like, okay, this is what we're due for today. You know, this is what it's protecting against. And I have the conversations as if we're, in 2006 or whatever. and I go from there. And I think that while you're having the conversations, that you're fully present, that you can sense those micro expressions and some concerns that families might have, and not miss those messages that might lead to just a divergence in understanding where they're coming from.
Great, thanks. I'm gonna let that be the last word, and I want to thank we're at the top of the hour, so I want to thank the panelists who've just been stellar, and thank the audience for taking the time to join us today. We hope you found the webinar informational and useful. Here are some contact informations. Maryland is not on this list. If you have Maryland-specific questions, I encourage you to contact the Maryland Department of Health. And in the next few days, you'll receive a link to the webinar recording, and we're very grateful that all of you attended. We keep vaccinating. Make sure you've gotten your own flu shot. It's not too late. And there's other viruses out there trying to get you. So get everybody that you love vaccinated. Thanks very much.